So the outline of the presentation is first to give you a little bit of background, talk about the methodology that was used for this study, look at some of the results, and then just some conclusions from this study. So a little bit of the background. Next. So pneumonia is one of the leading causes of childhood mortality in the world. 18% of all deaths among children under 5 are due to pneumonia. It is also one of the leading causes of deaths in children in Pakistan, with 85,000 deaths per year just in the country of Pakistan. Next. As we know, care seeking for pneumonia is quite low, and the percent who receive antibiotics globally for pneumonia is estimated to be about 42%. So globally, the WHO guidelines recommend that pneumonia with fast breathing can be managed by trained community health workers with oral antibiotics. And for severe pneumonia, where you have lower chest indrawing, normally the first dose can be given by the community health worker and then referred to the health facility. So that's for severe pneumonia. That's the current WHO guidelines. But what we know is that in many countries, this is not feasible or it's not practiced because there's poor transportation, there's high costs of seeking care at health facilities, there's a long distance to the health facility, or there's cultural perceptions that prevent people from seeking care at health facilities. Next. So the Hazir study in 2008 compared outpatient treatment with oral amoxicillin and inpatient treatment with injectable ampicillin for severe pneumonia, and found that the outpatient treatment of the WHO-defined severe pneumonia is actually equivalent to the hospital treatment with injectable antibiotics. So based upon that knowledge, we expected that community treatment of severe pneumonia would result in increased care seeking, increased treatment compliance, fewer treatment failures, and reduced economic burden for the families by lowering the treatment costs, the travel time, and the opportunity costs. So that's why we did this study. And the study objectives were, first of all, to look at increased care seeking from lady health workers within 24 hours of recognizing ARI symptoms in children in the selected clusters in the district of Kharagpur. We wanted to determine whether there is equivalency in the clinical treatment failure rates among children 2 to 59 months old with the WHO-defined severe pneumonia in clusters receiving the community treatment with oral amoxicillin versus children in the control clusters who received the standard care. The standard care was just providing the first treatment and then referral. And then really for this study that I'm going to be presenting, we're going to estimate the direct and the indirect costs of treatment of severe pneumonia from a household perspective, which is a little different than the first two studies that we've been looking at for the two arms of the study. So next. So a little bit about the methods. First of all, just briefly, this district in Kharagpur is a district in the northern part of Pakistan. The topography varies quite a bit from plains areas to mountains. And so you have much of the population living in the plain area, and they have better access to health facilities. And then you have populations in the mountains where health facilities can be several hours away in terms of seeking care. In Pakistan, the Union Council, that's called the Union Council, is the smallest administrative unit with a population of about 15 to 25,000. And each of those union councils typically has at least one basic health unit or rural health center in that union council. So just acknowledgements for the support and financing of your CID and WHO, and of the collaboration of Boston University, the University of Edinburgh, and of course the Lady Health Program in Pakistan.
Affordable after development stop funding, and how best to finance iCCM in the long run, and that looks at things like insurance or government budgets, how it should be financed. So for me, all those areas are important reasons to look at costs. So an example of that is from the cost alone. Sometimes it doesn't seem worthwhile to provide iCCM services, but it may actually be cost effective depending on the alternatives. So areas of cost effectiveness are, for example, if we shift tasks from a health center to a community, we may be reducing costs of the health center. So purely looking at the cost of the services in the community doesn't give us the whole picture. In another way, if we identify and treat cases quickly in the community, then we can save costs for the family and also for the health services overall. So these are not always measured when we do cost analysis, but they're important in decision making. Next. So some of the main cost effectiveness aspects that we should be looking at are the main cost drivers. And the main cost drivers are really a ratio between the numbers of patients treated, the numbers of CHWs, particularly if they're paid, and the time that they spend, and the cost of training, supervision, and management. And you will see these ratios in the presentations today. We should be taking into account travel time and the costs of community health workers and patients. So typically when we cost programs, we cost the health services part of the program. We don't look at the patient costs. And I think in order to make sure that the program is viable, we have to look at both aspects of it. Are the community health workers volunteered? Are they salaried? Are they paid by results? Do we have free services or do we have user fees? What about quality? Are we building up things like antibiotic resistance, which is kind of hidden cost of the health service over time? How are the referral systems working? What are the referral rates? The speed of diagnosis and treatment, as I mentioned earlier. So a lot of these are non-financial costs, but it's really important to measure them in some way or another. Sustainable findings, the experiences, we don't have much on that at this stage because the projects mostly that we were looking at were snapshots of projects in their early stages. So I think at some stage in the future we need to try and do a longitudinal study of something that's been an NGO program and then scaled up to national takeover by government, housing, and finance. So I think that would be very useful for the future. But the typical ways in which they can be funded are government budgets. In some countries, that's a question of whether it should be national or local, national or community-based health insurance, or special funds, which I use for example, HIV/AIDS and TB in some countries, corporate social responsibility or special taxes. There are different tools around that can be used, and three of them that are quite well known. Emmanuel has been using a tool developed by the South African Medical Research Council. USA has an iCCM costing financing tool which Sage developed. UNICEF has an iCCM gap analysis tool, which some of you will be familiar with. So introductions. So we have Emmanuel Davio sitting on my left here from the South African Medical Research Council, and she'll be presenting on studies in Ethiopia, Niger, Ghana, Mali, Mozambique, and Malawi. Zina will be presenting on iCCM programs in DRC, Cameroon, Ethiopia, Sierra Leone, Uganda, Zambia, and another Zambia. And Eric will be presenting, Eric Swedberg will be presenting on behalf of Salim Saladin and taking children on patient costs in Pakistan. And I think that's important. So, yeah, we're done.
South African Medical Research Council. And the costing I'm presenting now was part of a wider evaluation. I say wider, although it had to be short. Short evaluations in the 6 countries, which you see here. I'm going to spend a little bit of time showing what we costed and why, because at the end of the day, the numbers which are going to come out of the analysis are completely dependent of what is included and what is not included. And I think it is the interest of those numbers up in the report, really what they cover. Next. For this purpose, it was 10 in Ghana and 600 in Niger. So we are looking at a very different picture. And we look also at the population per CHW, which varied from 630 in Malawi to 72 in Ghana. So when you look at the combination of all these factors, it's obvious that we cannot compare, results from one country to the other like that. There is also different additional costs because the existing health systems were different in the different countries. For instance, in Ethiopia, Malawi, and Niger, there were already an existing cadre of people who existed, who was already paid by the government. So we did not include those salaries. You will see also that under the word CHW, we cover a wide variety, and it will be very interesting because the profile of the one we have happened to cover in our country, the countries we cover, compared to the one that Zina will represent. We have us, in 5 of the 6 countries, it was paid workers. In one country in Ghana, it was volunteers. Washington, I think it's mainly volunteers, I think. And you see also that for Mali and Mozambique, where there was no pre-existing cadre paid, you see that the salary per month was $80 in Mali and $40 in Mozambique. So also huge variations. The number of days of training was also very different. So obviously, training would be that much more expensive if there is that many more days. And the number of CHWs per supervisor varies from 30 in Ghana to 3 in Niger. So you can see then that the supervision cost will, per CHW will turn out to be also affected by this ratio. So if we look, the annualized cost per CHW, so obviously per year because it's annualized. So those fixed costs per CHW vary from 55 in Malawi to 933 in Mali. But you can see that in Mali, there was no pre-existing system. So all the costs have been attributed to the iCCM. So if we say then, what is the share of the CHW fixed cost per treatment? You can see that it will vary from 0.01 in Malawi to 12 in Ghana. So there is a big variation. Next. So if we recap, the cost per treatment is made of the share of the CHW cost, which as we have seen varies a lot, and the cost of consumables. Some of the cost of consumables, for instance, you see in Niger, the cost of consumables at 3 is much higher than the other because that included additional drugs for malaria, as SAC something. I'm not a clinical person, so I don't know. So that explains the difference in the cost. In Mali, the cost of connecting is also higher because as drugs arrive down, when it goes from national so the national costs, which are the same, when they come to the district level, so for instance, the cost of one unit of money, when it arrives at the district level, it must become 120, and when it arrives at the local level, it becomes 150. So that also represents what is the reality of what also the cost at the local level. In some countries, like Ghana and Mali, there were money paid by patients. And so that has been done per treatment. I just want to say also that in the cost of consumables, I have included the cost of the malaria consumables. Even if they are given free by the Global Fund, they are still a cost. And there is no guarantee they will be given free forever. Or those drugs which are paid by UNICEF now, they are still a cost whoever is paying them. So, when we saw, sorry, we go to the next one. Yeah, thanks a lot. When we see the importance of the level of utilization on the cost at the bottom, on the bottom line, we said, okay, is there a possibility with the, in the existing areas, with the existing CHWs, to increase the number of people they see? We are very aware that that issue of what affects demand is quite a long story, and there is no time to go in details here. I can see David's eyes becoming less friendly by the second. No, is it okay? I'm sorry. So, but the thing is that is it feasible at all in terms of time to see more patients? So we looked at the time per visit, and from that we compare the results of the work that Zina and David have done of about half an hour per visit, with some of the works we have done around 71 lives, who gave also very close to half an hour per visit across 6 countries in Africa, not all the same, some were overlapping. So it's okay, that seems to be a reliable enough thing. And in those countries where people are based at the health post, we did not have travel time. In those countries where it was home visits, we added travel time. And so we said, okay, now the number, and you see that now I'm not talking treatments, I'm talking visits. Because in practice for each treatment, we have assumed, and it might be a conservative assumption, that there is an additional 20% of people who come and were not treated, either because they did not need to be treated, or because there was no drugs, or something. So now, and we say, in fact, that it still takes time for the CHW. So, and it might be that 20% might be too conservative. So we say, if the number of visits per CHW per year, basically, it's number of treatments plus 20%. It means that for the current level of utilization, that this number on the second line, if you use the number of hours per week on iCCM visits per CHW, you see that in Niger, it's almost 9 hours a week. And it goes down to 1 hour a week in Ghana. That includes the patient contact, the travel time, and that includes also spreading the time on meetings, because you need a